I'm Ann Shookett. I'm director of CDC's National Center for Immunization and Respiratory Diseases. And I want to welcome my co-presenters, Dr. Beth Bell, who's the director of the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention, and Mick Ballesteros, who is the lead non-communicable disease staff in the Division of Global Health Protection in the Center for Global Health at the Centers for Disease Control and Prevention. This is your CDC-only session, and we're excited about the chance to speak with you today about a few of the priority areas in global health, focusing in on the role or value of science in global health initiatives. I hope this will be interactive. We've tried to make fairly short presentations so that we can try to get into some of the issues you're more interested in. I think collectively we probably have about 60 years of CDC experience between us. So after our presentations, we're happy to take questions. And I think we're probably going to leave questions to the end so that we can go through the three presentations first. So our first speaker, Dr. Bell, is going to talk about infectious disease outbreaks worldwide and the role of science in them. So please welcome Dr. Bell.
Morning. I will also fiddle with the microphone here for a moment. Okay. Morning, and nice to see all of you, and nice to be here. So I thought what I would do today is just spend a little bit of time talking about a few examples of the role of a good science base and strong capacity in influencing the outcome of outbreaks. Before I do that, I thought I would start off with a kind of current example of kind of unfortunately where we oftentimes find ourselves in outbreak investigations around the globe these days. And so that I thought I'd tell you a little bit about where we currently are with the Ebola outbreak that's going on in West Africa. So this is an outbreak that was first reported on March 25th when Guinea and the World Health Organization reported an outbreak in Guinea, and the following day cases were identified in Liberia. This map's a little bit out of date, but cases have been widely distributed in Guinea, including in the capital, Conakry, and multiple counties in Liberia. Talk a little bit more about the sequence in a moment or two, but it shows that the virus is closely related to the Ebola virus variants that we've been seeing in Gabon and in DRC in the Congo Basin. As of sort of a few days ago, there were 231 suspected and confirmed cases with 155 deaths in Guinea, 13 in Liberia with 11 deaths, and unfortunately, there are cases continuing to be reported in Guinea, both in Conakry and in Gekadu, so not over there. In Liberia, it's been now 3 weeks since the majority of the contacts, and so we're actually hopeful that we may be out of the woods in Liberia. A little bit about how we at CDC work in the context of these global outbreak responses that involve collaborations with many, many partners. We first sent 5 people to CDC at the end of March to mostly focus on epidemiology and community education and data management and such, and have sent additional teams several times for a number of different purposes, including beefing up their laboratory diagnostic capability to add serologic testing. We've also sent a number of people to Liberia, including people from CDC Atlanta and also some people from the field epidemiology training program in Kenya. There are a number of considerations with this outbreak. As you know, this is the first reported Ebola outbreak in West Africa, so the obvious question is why. We're interested in the potential role of bats as a reservoir. Continuing with our theme of the morning, the absence of human disease surveillance and laboratory and epidemiology capacity in West Africa certainly played a role, as I'll show you in a moment. The sequence has provided some useful information. I wanted to just sort of highlight one aspect of what we've been doing in this outbreak in West Africa, and that's the use of an EpiInfo software tool that we developed in Uganda in the context of our viral hemorrhagic fever work, which I'll talk about a little bit more in a minute, which we modified and have been using in Guinea. This is part of an open source EpiInfo platform that CDC has made available for decades. And it improves contact tracing for VHF outbreaks and facilitates collection and management and analysis of many sources of data coming from many different streams and puts them all together in one place. And this is a screenshot, which as I see, if I can't read it, you probably can't either, but case management, contact tracing, there's an analysis component and a way to plot transmission patterns. This is an EpiCurve that was generated by the EpiInfo software. And as you can see from this, the outbreak was detected about 16 weeks after the first recorded case, so allowing for multiple chains of human-to-human transmission in multiple locations in 2 countries, obviously greatly increasing the complexity and the challenge involved with controlling the outbreak. I said I would mention a little bit more about the sequence, and these are data actually generated by a group from Germany, which just illustrates actually the value of molecular epidemiology in such outbreak investigations. It shows that this virus is a variant which is ancestral to earlier variants found in the Congo Basin. It tells us that the outbreak didn't occur from recent spread directly from the Congo Basin and suggests that the virus was likely been present but undetected and circulating in this area for quite some time. So now I'd like to shift gears, and I'm going to actually focus on Uganda and provide a couple of examples of contrasting results of response to outbreaks that can happen with a strengthened science base and strengthened laboratory capacity. And I'll mention that all of the work that I'm going to be talking about here is a collaboration among many, many different partners, but certainly also just from the point of view of funding, to mention that this has been a shared effort from CDC, the Department of Defense, and USAID. These examples that I'm going to give you also are particularly timely because as many of you have heard, and I'll mention a little bit at the end of my talk, we've been working quite intensively recently around global health security and chose 2 countries for pilot projects in 2013, kind of as a proof of concept. Uganda is one of them. And so these examples I'm going to give you kind of provide a little bit of a preview of the kind of things that we hope can be accomplished through a global health security agenda. So in Uganda, in viral hemorrhagic fever surveillance, first of all, we've been beefing up surveillance since 2010 in collaboration with the Ministry of Health and the Uganda Virus Research Institute, UVRI, as well as CDC Uganda, which is primarily focusing on PEPFAR. We've expanded to 12 surveillance sites, developed a standard case reporting form, electronic databases, including this EpiInfo module that I mentioned, and established diagnostic testing, which I'll go into in a little bit more detail in the next slide. We spent a lot of time on training, including regional training and involving lots of district and hospital staff across the various surveillance sites. We've put quite a bit of work into laboratory. Currently, the UVRI laboratory has a capacity to do antigen detection, IgM and IgG, ELISA, and RT-PCR for all of the viral hemorrhagic fever agents shown on this slide. The diagnostic testing is performed in an upgraded BSL-2, BSL-3 high containment laboratory based at the Uganda Virus Research Institute. And there's been standardized communication protocols about all of the logistics associated with the diagnostic testing. So why bother with all of this? Here's a couple of slides to just give you a sense of what the impact has been. This is a slide which essentially the message here is that there have been 5 Ebola and Marburg outbreaks detected in this region of Uganda and the Congo Basin just since 2010. Detecting more outbreaks is good because it means that our surveillance and improved diagnostic testing are working. If you just focus your attention on the table on the top of this slide, this table shows the number of days from detection of the first case to the last case and the size of these outbreaks. And as you can see, perhaps with the exception of the Bundibugyo outbreak in DRC, these outbreaks have been detected rapidly. They've been quite small, and the number of deaths, relatively speaking, have been limited. And this is another way to look at that. This shows viral hemorrhagic fever outbreaks in Uganda from during the time before and since. We've been strengthening the diagnostic and surveillance capabilities there. And again, I think that you can see, perhaps with the exception of the DRC outbreak, where we really don't have the surveillance capabilities that we do in Uganda, that we've had more outbreaks, which is good, and that they've all been quite small and limited in terms of morbidity and mortality. Now I'm going to shift gears, sticking with Uganda, but moving to a different pathogen, and that's plague. And I'd like to just spend a little bit of time talking about the work that we've been doing on plague in Uganda, once again with kind of similar areas of focus, but tailored for the needs of the particular pathogen, the types of outbreaks that it causes. We've been working for quite some time in the West Nile district of Uganda, primarily originally focusing on plague. This network includes 13 clinics and hospitals and an Arua field laboratory. Very, very importantly, this network involves village volunteers, native healers, and a cell phone reporting system. The role of the native healers in particular, I think, is quite important. And I myself was there about a year and a half ago. The native healers have essentially taken on the responsibility for distinguishing illnesses that they can, in fact, do something for, and illnesses where they understand that they probably can't do anything for. And they've been very instrumental in reporting those illnesses using the cell phone reporting system, and in facilitating getting patients, a number of whom turned out to have plague, onto the backs of motorcycles and to some of the clinics in the area. The native healers are really quite strong in terms of their science. I saw several notebooks filled with names of patients that they've seen, what the symptoms were, and what the outcomes of either their intervention or their referral to the clinics were. The other component of what we've been doing in about plague has to do with the zoonotic and environmental components, and as a result of a number of case control and other kinds of studies, we've identified kind of a key indicator for mitigation, and that's rat fall. And so the deaths of rodents, as reported to us by village volunteers, set in motion enhanced human surveillance and also preventive house spraying for fleas. Another aspect of our work in Uganda has been diagnostics, because early diagnosis is critical for saving lives. We've developed a dipstick assay for plague using a lateral flow technology. This dipstick provides results in minutes as opposed to the time that it takes for laboratory confirmation, and these dipsticks are available in all of the regional Arua plague clinics. They use them to rule out and rule in plague cases with confirmatory testing done at the Arua City Lab. So what's been the impact of this? Well, I decided showing you here the results of a plague outbreak in Madagascar, where there's essentially nothing in particular done with respect to controlling plague outbreaks from 2005. And what you can see on this slide is that the outbreak was recognized on day 21 after there'd already been 2 chains of transmission. There are a total of 11 cases, including essentially 8 secondary cases, I guess we would call them, 3 deaths, and by the end of it, with these 8 cases that were identified, over 500 people had to be prophylaxed. And as you can see, it involved 3 villages, and it was pretty complicated. In contrast, this is a plague outbreak from Uganda in 2012, in which the outbreak was identified after 1 transmission from an index case to 2 secondary cases. Unfortunately, there still were 3 deaths associated with this outbreak, but it was identified much more quickly, and 130 people had to be prophylaxed with a much less complicated outbreak investigation, contact investigation. Looking longitudinally at plague in Uganda, this slide illustrates a couple of things, one of them being that the incidence of plague is cyclical, and I'm certainly not suggesting from this slide that we take credit for the decline in plague incidence in Uganda, but I think that our efforts to respond to outbreaks much more rapidly and improve our ability to detect them really has played a role in reducing plague incidence in Uganda. I'm just going to say a couple of words about acute febrile illness in Uganda, and then I'll be done. We're interested in building on the plague platform to expand to doing surveillance for other causes of acute febrile illness. This began in January 2014 at 1 pilot clinic. This, at this point, is a research project. It's a study. It has IRB approval. And what we're doing in this 1 clinic is enrolling about 20 adults and children every week, collecting acute and convalescent phase specimens, of which we're finding about 40% are malaria positive. The specimens are sent to the UVRI lab in Entebbe for initial testing for arboviruses and VHF. They have that capacity. And then at the moment, we're then shipping the specimens to CDC to test for some other pathogens that currently there is not capacity in country. There we go. This is a map of Uganda which shows all of the different CDC surveillance sites. And I'm showing this slide for a couple of reasons. One, remembering that Uganda has been one of our pilot sites for global health security. One of the things that we would like to do and think we can do and have made some progress doing already is linking all of these vertically oriented surveillance sites into something which is more comprehensive, takes advantage of the strengths of the various different sorts of surveillance sites, and will provide more benefits, especially we think to the country, and can be leveraged in lots of different kinds of ways. And I suspect that maps of many other countries may not look that different from this one. So what we'll be doing, as I mentioned, we do currently have a fully functioning arbovirus lab in Uganda, which we've been building up over the last few years in parallel to the VHF work. And so now, for example, we can diagnose yellow fever in Entebbe very quickly. In the future, we're hoping to expand our surveillance sites, incorporating some of those other vertically oriented sites that I mentioned in Uganda. We'll be able to use a motorcycle network for specimen transport to laboratories that was developed in the context of PEPFAR, and which we've already expanded to use for a couple of other pathogens in the context of our pilot project. We're hoping to build national capacity to diagnose some of the other important endemic diseases in Uganda and build on other parts of the global health security work. So just now that I've mentioned global health security 4 or 5 times, I'm just going to say 1 or 2 things about this. You're going to be hearing a lot more about it from Tom Kenyon at a session on the Millennium Development Goals tomorrow afternoon. So I encourage all of you to go to that session to hear in more detail. But I just thought I would give a little bit of preview of how we're conceiving of this. Not just at CDC, not just in the U.S. government, but this is something that now I think is actually has a lot of interest broadly globally. So global health security is about recognizing a number of risks, a number of opportunities, and then identifying some priorities. Risks include the risks around emerging organisms, around drug resistance, and around the intentional creation of pathogens. There are a number of opportunities at this time that I think, as I mentioned, Tom will be talking about in more detail. There's a societal commitment. There are new technologies that make it possible to build capacity, and successes, I think, as we've seen in Uganda, lead to further success. We have a number of priorities, including preventing outbreaks whenever possible, detecting them rapidly, and responding effectively. The need for global health security is pretty clear. I don't think any of these factors will be news to any of you. Globalization and the risks associated with poor control and prevention of infectious disease outbreaks. The bottom of this slide in red, which hopefully you can see, is that in the President's FY15 budget request to Congress is an initiative on global health security for CDC where $45 million is being requested. We're certainly hopeful that some funding will see the light of day, will allow us to move forward. How would we approach, sort of as a very broad global health security? This is about core capacities to address threats, prevention, including things like immunization, limiting the spread of resistant organisms, promoting evidence-based decision-making for policies and strategies, detection and improving detection, including some of the examples I showed from Uganda about laboratory epidemiology and field epidemiology training and response, including building IT capacity and further training the workforce. So I think I'll stop there because I've already talked quite a bit, and thank you all for your time and look forward to discussion at the end of our session.
Well, thanks so much, Beth. We're going to continue with the presentations. And so could we get the second set of slides, please? I'm going to talk about the value of science in global immunization initiatives. And I hope that this can be stimulate some questions from you. I know a number of you are students in universities and are getting deluged by science, but out in the world of public health, science is sometimes under attack and not always valued. So I hope to give you my sense of why I think it's very important for there to be strong scientific underpinnings to what we do day to day in global public health with a focus on the immunization area. When we look at what's still killing children around the world, vaccine-preventable diseases continue to be a source of preventable deaths. Whether it's the deaths from pneumonia and diarrhea that pneumococcal conjugate, Hib vaccines, and rotavirus vaccines could prevent, or the ongoing deaths that we still have from measles, 122,000 deaths from measles last year, for instance. We think that vaccines still play a role in being able to help have some impact on these kinds of ongoing problems. It's really been extraordinary for those of us who are a little older in this audience to think about what kind of investments are being made right now in global health. This was not the case 20 years ago, but it's really been an exciting era where more and more governments, foundations, NGOs, multilaterals are putting resources into global health. Obviously, a lot of the money right now is going for HIV, or for AIDS, TB, and malaria, as they say, most of which is for AIDS. But there's a number of governments and partners that are very interested in immunization. I've put arrows against the particular ones, including the U.S. government through both CDC and USAID investments, WHO and UNICEF, Gavi, or the Global Alliance for Vaccines and Immunizations, and of course the Bill and Melinda Gates Foundation. Some of the larger global immunization efforts and partners are shown on this slide. For more than 20 years, the Global Polio Eradication Initiative has been trying to rid the world of polio. It's taken a lot longer than it took to eradicate smallpox, but we have made a lot of progress, and in the discussion time, I'd be happy to talk about that if people have issues. The Gavi Alliance was formed in 2000 and is the largest public-private partnership now that is focused exclusively on immunization in the poorest countries of the world. There are a number of initiatives that are vaccine or disease specific that are listed here, and a number of entities that are making a lot of progress or focus on the immunization world. I want to talk a little bit more about Gavi. I was part of the Gavi board from 2010 to 2012. This was a period where Gavi had reached the point of investing about $1 billion a year in global vaccine efforts in the poorest countries of the world. The board was struggling with the question of whether any of the resources that Gavi invested should be focused on answering questions about vaccines versus delivering vaccines. The priorities of the Gavi Alliance were to introduce new and underutilized vaccines into the poor countries and to strengthen health systems so that they would have strong capacity to deliver those vaccines. Is there a learning agenda in that kind of organization? During my era on the board where I served as the representative of technical and health research institutes, my voice was being pushed by my constituency to speak up for the role of science and the role of thinking in the global immunization agenda. But many times the question of whether we should think or do led to this type of decision. Gavi was very committed to making sure that we could deliver and had questions about whether there was need or time to answer questions in the context of that. So in the remainder of my remarks, I want to focus on why I think it's very important for us to make sure that we can answer questions while we are not at all ignoring the need to scale up interventions to save lives and deliver health. So I want to do a few thought experiments. What if there were a new vaccine, like vaccine X, that could lead to a 97% reduction in disease incidence over the course of a few years following its use? This would be a breakthrough for Gavi. This would be a breakthrough for any government that was considering the use of vaccine X. What if I told you that this was not just a very effective vaccine, but it was actually really safe? We had a strong safety track record, very few adverse events. In fact, there weren't very few adverse events, there were 0 adverse events. What if I told you that this was an antigen-sparing vaccine? It didn't take a whole lot to produce the vaccine. You could, with very little, get a whole lot of vaccine out of it. What if I told you that there were no adverse events because none of the people who had this benefit actually had to get the vaccine, and it was antigen-sparing because no antigen was being delivered? This is the actual graph of the incidence of serious pneumococcal infections in adults in the context of introducing a conjugate pneumococcal conjugate vaccine for babies and toddlers. You get a 97% reduction in serious vaccine-type disease in the elderly and other adults without having to vaccinate them. What if I told you that when this vaccine was licensed for routine use, nobody knew that this was going to happen? And the only reason we figured out this was going to happen was because we had invested in surveillance that would capture it. What if you were doing post-marketing surveillance for an entity after you introduced a new and relatively expensive vaccine, but you alarmingly found that there was an increased risk of a serious intestinal blockage called intussusception, relatively recently detected after the first dose of rotavirus vaccine, in this case, was being used? The Global Advisory Committee on Immunization Safety of the WHO had to take up this question in 2010, and it was a very serious question. You may recall that in 1999, there was such a scary intestinal blockage noted very soon after rotavirus vaccines were introduced here in the US. The vaccines were, the program was halted and the company stopped making the vaccine. What if such a entity occurred globally with the second generation rotavirus vaccines? Well, it actually did. But what if, instead of just delivering the vaccine, you had invested in intensive evaluation in Mexico and other countries. We're grateful that the Mexicans, PAHO, and colleagues at CDC were investing in understanding the impact, the benefits, and risks that rotavirus vaccine introduction would have. They estimated about 12,000 admissions to hospital prevented because of rotavirus vaccine introduction, but 43 intussusceptions or intestinal blockages caused by vaccine. They documented about 700 deaths in young children prevented through the rotavirus vaccine, but an estimated 2 deaths possibly caused by intussusception attributable to the vaccine. The Mexicans and global health authorities were able to determine that there was a 300-to-1 benefit to risk ratio. It doesn't mean that anybody's happy that intussusception is potentially caused by the vaccine, but a strong life-saving impact of vaccines, not knowable if you hadn't invested in understanding this. The international health authorities through the WHO's Global Vaccine Safety Advisory Committee reviewed the situation and estimated that for developing countries in Africa and Asia, there was about 100-to-1 benefit in reduced deaths versus intussusceptions caused. And the global community and countries, ministries and so forth, determined it was important to continue to use rotavirus vaccines. Here's my third what if. What if you introduced a new vaccine in year 0, and by year 2 you had this phenomenal, approximately 50% reduction in the disease? Well, what if in the next year, year 3, you lost about half of what you had gained? Would you dispatch your investigators to the districts to determine if people were still giving the vaccine, if the vaccine wasn't being stored correctly, had the vaccine lost potency? Was there some escape from the vaccine in terms of viral change or bacterial change? What if year 3 was when you really needed to tell your health minister and minister of finance whether you were going to take on sustainability and pay for this vaccine yourself after Gavi stopped giving it to you for free? Year 3 is a pretty important time in vaccine introduction. Well, what if we could tell you that you will always have an increase in disease in year 3 based on modeling that was generated based on empiric data from a number of countries because of the dynamics of rotavirus disease, viral transmission, and indirect effects, that you'll always have older kids continuing to spread and a little bit of bouncing around. This pattern has been seen in developed and developing countries now, and no longer needs to be something that loses credibility for the program, but something that you can prepare your health minister and your finance minister to understand. What if there were a time where 1 + 1 actually is greater than 3? In poliovirus vaccinology, this turns out to be the case. The polio vaccines that we use around the world are generally trivalent, including targets against wild polio type 1, 2, and 3. But it turns out that trivalent oral polio vaccine is not as effective as bivalent or monovalent vaccine. There's competition between the viruses and not as good an immune response. Bivalent vaccine has been critical to the success in interrupting transmission in tough places like India. And the program was able to study bivalent vaccine, get companies to rapidly produce it, and introduce it to help further limit the spread of polio in countries where it's continued to be endemic. Polio, of course, is a paralyzing disease for life, a horrible condition. We're 99% down from before the Polio Eradication Initiative began. But science has been absolutely critical. The eradication effort is taking much longer than everybody wants. A lot of progress the past few years, but without a learning agenda or a scientific questioning, we would not be where we are today. The core of the polio eradication initiative involves routine immunization, which absolutely needs to be strengthened in developing countries, surveillance for both the clinical syndrome of acute flaccid paralysis, but also for the viral specimens themselves and the changes in the virus that can help us differentiate vaccine virus, which is expected when you're using oral polio vaccine, versus wild-type virus, which we're really trying to eradicate. Immunization days or supplemental immunization activities and mop-up care programs to really make sure that you can reach absolutely every child. Well, the role of the laboratory and laboratory science in polio eradication is actually extraordinary. I could spend about an hour on this slide alone, but I can just tell you that by doing genetic evaluation of the viral specimens, you can differentiate a picture of a whole lot of cases and a whole lot of dots changing over time to really understand transmission patterns. What you can see between 2008 and 2010 is not just fewer cases, but many fewer individual lineages. Right now in Nigeria, they're down to one single lineage of virus that's continuing to spread. Case counts can be somewhat misleading, but realizing, wow, we've only got one lineage left is very exciting in the prospects of being able to finally interrupt transmission in Nigeria. The laboratory scientists that have been part of this Polio Global Lab Network have helped use viral characterization as a molecular clock. Like what Beth Bell was showing you earlier, we can tell how long have these viruses actually been circulating. We can tell how strong is our surveillance. Are we missing cases because we have jumps in the patterns of viral strains? So the ability to have high quality molecular biology carried out in countries all around the world is a real scientific legacy that the Polio Eradication Initiative will be leaving. This map shows you how the Polio Lab Network has expanded to now include a measles and rubella lab network and surveillance network for many other viral diseases. The dots on this map really are a testimony to that capacity that we now have worldwide. Most countries of the world, a laboratory that can do up-to-date molecular characterization of viral specimens. Very important for a number of conditions and concerns. So I think a critical contribution of science to many global public health initiatives. Well, at a global health meeting, it's very important to talk dollars because dollars really do drive progress. What if the cost to fully vaccinate a person went up tenfold in a period of 15 years? Would that price you out of trying to take this on? Would that make investments completely impossible? Well, what if your surveillance and modeling and economic analysis and vaccine effectiveness could help you translate what those investments were? The slides I showed you before was the cost to fully vaccinate a child here in the US through age 18, and this slide shows you that if you invest in vaccinating children over a 20-year period here in the US, you not only prevent 300 million illnesses and 700,000 early deaths, you save $1.4 trillion. Now here in the United States, sometimes policymakers don't really like to look at future cost savings. You wouldn't really want to have to wait 20 years to be able to justify your program. But in more and more countries around the world, cost effectiveness really does drive health investments and public investments. So the value of scientific studies that can help document return on investment can make a case not just for your research project, but really for the benefit of the country's programs. I've talked about a lot of different kinds of information and different purposes of information. When I think about immunization, there are information needs at the local level, at the national level, at the regional level, and global level. There's a lot of different types of information or scientific investment that we might want to make. We may need to understand disease burden or program impact, As I mentioned, the laboratory characterization and cost effectiveness. Adverse events are really important in the vaccine world. The first generation rotavirus vaccine was sunk based on adverse events and our inability to prepare, anticipate, and understand them. But it's very important worldwide as newer vaccines go into countries for there to be investment in adverse event detection and framing of the potential risks in the context of potential benefits. Very important to invest in vaccine efficacy and vaccine effectiveness after vaccines are used in real populations on a large scale, and to track vaccine uptake and understand where we're failing. There's also, in a scientific world, an emphasis on randomized controlled trials and all of the scientific investment in pre-licensure study of vaccines. Hundreds of millions of dollars go into the pre-licensure development of a vaccine, including clinical protection studies. But in the global immunization agenda, it's vital that we follow vaccines as they are used, look at what they do post-introduction. And in the Gavi context, it's very important that we be following these impacts pre-graduation. Gavi provides free vaccines to countries for 5 years. The poorest countries have cost sharing over a longer period of time. But as economies improve in developing countries, more and more countries are graduating from Gavi assistance. Very important for ministers of finance and ministers of health to know what will we get if we continue to invest in this vaccine. It's a different thing to take a free donation than to put your own scarce national budget into a vaccine. So we think that it's very important for the scientific learning to continue and the case of what the immunization programs are making to be made to the policymakers nationally and regionally. Now, information is great. I'm a data nerdy kind of person, but information is sometimes confusing. And if you look at this slide for a couple seconds, you'll realize that this is misinformation, not just information. In public health, in global health, not all data is good data, and bad data is often worse than no data. There are ongoing evidence needs in the life cycle of an immunization program, probably similar to what's necessary in many public health agenda programs. But in immunizations, we need to understand what's going on in people in terms of disease and adverse events and their social acceptance. We need to understand the product itself, that bivalent versus trivalent vaccine, but also what's going on in the system that distributes the product, the cold chain system, the predictability of supply and demand. We also need to understand what's going on with the program, and this takes a huge set of operations research priorities to understand our efficiency, do we have a self-correcting program, and whether our program is really reaching everyone. I think all the things I've listed on these slides are priorities for global immunization initiatives where students and researchers can contribute to focusing on particular components. I like to think of the immunization policy and control of vaccine preventable diseases in a positive cycle, where by monitoring a condition and accumulating evidence, you can review the evidence and either establish or update a policy, leading to implementation or refining implementation, but with an ongoing commitment to monitoring. This idea of a self-correcting system is absolutely vital, and it's why we don't really want to just get a whole lot of money and deliver an intervention, but we want to make sure our intervention is having the effect we expect, and that if it isn't, we have a way to correct that. Information or evidence is great, but it can also be associated with danger. There's an important danger of not looking. With the pneumococcal conjugate vaccines, we would have missed a phenomenally important effect, an effect that actually made the difference between countries in Europe being able to afford to introduce the vaccine versus delay, because the indirect effect made the vaccine much more cost effective. There's a danger of looking without the right tools. Surveillance for Hib disease in India suggested to leaders there that they had no Hib disease. It's partly because it's very difficult to do surveillance for finicky bacteria that are exquisitely sensitive to antibiotics, yet the benefits of vaccinating are high. In the India Hibbs story, many people think that bad data was worse than no data for their leading to many years of delayed policymaking. There's a major danger in ignoring adverse events with immunizations. You may have heard of India cutting their HPV demonstration program short because, basically because a girl drowned in a well. Japan interrupting their use of rubella vaccine over some concerns, on and on, countries overreacting to events that follow vaccine without a clear linkage. And I think critically a danger of failing to self-correct. Scientific evidence or evaluation or monitoring can be a huge insurance policy on vaccine investments. I tried to make that case to Gavi, only partially successfully. I think that scientific investments and evidence can help convert a vicious cycle or a dangerous ring of fire into a virtuous cycle or a ring of fun. So I think with that, I'm going to conclude my remarks and turn things over to our next speaker, who is Mick Ballesteros, who's going to be talking about the global non-communicable diseases agenda.
So good morning. I'm going to talk about something a little different, non-communicable diseases. I was very happy to hear in the first session some acknowledgement of the growing public health global problem of NCDs, and happy to see over the next several days there are a lot of talks, posters, and sessions about this. So we're going to dig in a little bit more over the next 15, 20 minutes or so. So what I'm going to talk about is first a definition of NCDs, talk about the global burden of NCDs, epidemiologic transition, NCD risk factors, road traffic injuries and burden, surveillance, and WHO and CDC's response. So first, let's talk about the definition of non-communicable diseases. The World Health Organization classifies deaths into three categories: communicable, maternal, neonatal, and nutritional disorders, non-communicable diseases, and external causes or injuries. So WHO and other organizations think of NCDs as things that are not passed from person to person, not infectious, not contagious. They have a long duration, generally slow in progression, essentially chronic diseases. But at CDC, our definition is a little broader. In addition to chronic diseases, we include injuries, things like motor vehicle injuries, drownings, poisonings, and violence, self-harm, and assaults. And environmental conditions, things like air pollution, climate change, natural disasters, and lead poisoning. So at CDC, this typically involves 4 centers within the agency: the Center for Global Health, the National Center for Chronic Disease Prevention and Health Promotion, the National Center for Injury Prevention and Control, and the National Center for Environmental Health. So for us, most of the causes of global deaths are non-communicable diseases. The latest global estimates from 2010 find that almost 53 million people died worldwide of all causes, and of these, about 75% of these causes are due to non-communicable diseases and injuries. So that's almost 40 million people a year dying. Cardiovascular disease accounting for about 30%, cancer 15%, and injuries 10%. So the Global Burden of Disease study lets us compare the leading causes of death in 1990 and 2010. So I realize that this is a very hard slide to read, but the thing to just see here is that the blue items are chronic diseases, the green are injury, and the red are communicable diseases. So in both 1990 and 2010, ischemic heart disease and stroke were the leading causes of death worldwide. The lines between the lists essentially show how the causes have changed from 1990 to 2010. And really, the thing to look at is for chronic diseases, the blue causes, the lines are essentially going up, and for communicable diseases, the lines are essentially going down, essentially providing some evidence that the problem of non-communicable diseases is growing in the world. If you look at this list for the United States, you'll see that most of the causes are chronic diseases, and injury. In fact, in 2010, there was really only one communicable disease in the top 30, essentially influenza. But if you look at an area like sub-Saharan Africa, you'll see still the continuing problem of communicable diseases. However, you do see increases and rises in non-communicable diseases and injuries. So beyond looking at the rankings or the leading causes of death, here's another way of looking at it. Again, this is taken from the Global Burden of Disease study. And here, again, the blue boxes are chronic diseases, the red are communicable, and the green are injuries. And what you see here is each box is essentially the proportion of deaths due to that cause. So for the world, as we saw earlier, about 75% of all deaths are due to chronic diseases and injuries. If you look at the United States, much bigger area for chronic diseases, right, NCDs. But if you look at sub-Saharan Africa, again, the continuing problem of communicable diseases. So we see that NCD burden is very different when comparing countries by income level. But it's also interesting to look to see what's being projected in the future. So here, the dark areas in each circle are NCDs. The white is injury, and the gray are communicable diseases. And the circles on the left are the high-income countries. You'll see 2008 compared to 2030, which is the projection 2030, very little change. Among middle-income countries, slight increases in non-communicable diseases, but even in the low-income countries, by 2030, it's being predicted that non-communicable disease is going to be the leading cause of death, even in those countries. So to do nothing is not an option. Estimates suggest that NCDs will have a cumulative output loss of $47 trillion by 2030. This represents 75% of the global GDP in 2010, or roughly $63 trillion. And this sort of economic burden really threatens country level and global development agendas. So we could essentially do talks on each topic area, but I just wanted to mention some things about specific causes. So for cardiovascular disease is the leading cause of death globally, an estimated 17.3 million deaths in 2008. Over 80% of cardiovascular disease deaths occur in low and middle income countries, and the number of deaths are projected to reach over 23 million by 2030. Cancers, estimated over 8 million deaths in 2012. The main causes of cancer death globally are lung, liver, stomach, colorectal, breast, and esophageal. Africa, Asia, Central, and South America account for 70% of the world's cancer deaths. And it's estimated that annual cancer cases will rise from 14 million in 2012 to over 22 million over the next 2 decades. So diabetes, almost 350 million people in the world have diabetes, which that results in an estimated 1.3 million deaths. More than 80% of diabetes deaths occur in low and middle income countries. WHO is projecting that the deaths will double between 2005 and 2030, and it's the leading cause of blindness, amputation, and kidney failure. Chronic respiratory diseases, these include things like asthma, chronic obstructive pulmonary disease, COPD, occupational lung disease, and pulmonary hypertension. It's estimated that over 230 million people in the world have asthma and 64 million have COPD. In 2010, 3.8 million died from chronic respiratory disease, including almost 3 million from COPD, and 90% of the COPD deaths occurred in low and middle income countries. So in general, the projected deaths from NCDs are increasing, shown here by the increase in lines for cancer, ischemic heart disease, cardiovascular disease, and road traffic deaths, while other causes are showing stable and even decreasing trends over the next several decades. So some would say that we're undergoing an epidemiologic transition that's really changing the balance of disease in populations in the world from communicable diseases to non-communicable diseases. So why is this? One obvious reason is that the population of the world is aging. The proportion of the world that's 65 and older is increasing and will continue to increase over the next several decades. Public health successes in some areas are increasing life expectancy, so populations are basically living long enough to begin getting chronic diseases. Another big reason for the epidemiologic transition is the dramatic increase in urbanization. So urban areas across the world are getting larger, and people are slowly and increasingly migrating from rural to urban areas. In 2010, for the first time, the number of people living in urban areas surpassed the number of people living in rural areas, and that discrepancy is going to be increasing over the next several decades. So with urbanization, more people living in city environments, come specific lifestyle influences that really dramatically affect non-communicable diseases. In cities, people tend to smoke more, people drive cars and ride motorbikes more, which basically means they're walking less, their level of daily physical activity is going down, and food choices are very, very different than in rural communities. Across the world, urban areas are becoming westernized in terms of the food, with an influx of fast foods, and which is convenient and inexpensive. The most common food and beverage companies in the US and in North America are really now the most common across the world. Again, evidence of the globalization and the westernization of food. So in public health, there's often the separation between infectious diseases and non-communicable diseases in terms of priorities, interests, expertise, activities, and resources. But many argue that we need to start thinking beyond that. In fact, I think we're learning more and more that the separation between we're learning more and more that many non-communicable diseases actually have infectious etiologies. So here are some for you to consider. And in fact, I think some people are beginning to think of cervical cancer as a vaccine preventable disease because of its relationship with HPV. So we know infectious diseases are communicable, but I think we need to start thinking about modern lifestyles as also communicable. Specifically, one's diet, level of physical activity, reliance on automotive transportation, tobacco and alcohol use, stress, urbanization. We know that the more you're around these types of lifestyles, the more you're likely to do that. So for non-communicable diseases, it's not just diseases themselves that are important to understand, but it's the risk factors as well. It's the risk factors that are often targeted for prevention efforts. So modifiable risk factors, things like tobacco, alcohol use, diet, and physical activity, metabolic risk factors, high blood pressure, high cholesterol, glucose, obesity, interrelate with each other and are directly associated with major diseases. So this makes the world of NCDs complicated, but the good news is that many of the leading NCD diseases have common risk factors, and I think we saw this slide earlier this morning. So strategies, initiatives that address specific risk factors like tobacco use will actually, if done well, actually will have an effect on a variety of diseases. So because at CDC we think of NCDs as more than just chronic diseases, I also wanted to talk a little bit about global injuries and specifically road traffic injuries, since it's a priority domestically and globally for CDC. So annually, road traffic injuries account for 1.3 million deaths. Up to 50 million people are injured, and many have long-term disabilities. It's the leading killer of children over the age 5. 90% of the deaths and injuries from road traffic accidents occur in the poorest countries, and it accounts for about $500 billion a year. Unfortunately, if nothing is done, the number of road traffic deaths will increase as urbanization continues and poor countries begin to develop economically. So more individuals will be able to afford their own cars, their own motorcycles. This will increase traffic volume, increase exposure to risk. In Asia and Southeast Asia in particular are showing large increases in road traffic deaths each year. So you would think the United States, the richest country in the world, would have it all figured out. In fact, we're kind of in the middle of the pack when you compare our motor vehicle death rates to others across the world. So here's some select countries, those in green being high-income countries and those in blue being low and middle-income countries. And the death rate in the United States, in the middle in red, is more comparable to Poland and Vietnam than the death rate in the UK and France. Our rates are actually 3 times more than the Netherlands and Sweden. So although I think we have a lot of expertise and experiences that we can share, I think there's also a lot the US can learn from other countries that sort of address this issue and have more successes than us. It's also important to understand that unlike the United States, globally about 50% of traffic deaths occur among pedestrians, cyclists, and motorcyclists. So intuitively, this makes sense. These road users don't have this metal frame of a car to protect them when they're hit by a larger vehicle. And if you look at the types of people who are killed, this is the United States compared to Cambodia, which is a country that the CDC has done a lot of road traffic work in. You'll see a very different picture. So the United States, the yellow are deaths due to drivers and passengers of four-wheeled vehicles. In the US, about half the road traffic deaths are due to people in cars, basically. Whereas the dark blue are deaths due to riders of 2- and 3-wheeled motorbikes and motorcycles. And in Cambodia, that's about 2/3 of the deaths. So depending on the country, the mix of road users, the local conditions, the local laws, the risks, challenges, and solutions are different. But it's not all doom and gloom. We actually have made a lot of progress in the United States over the last several decades. Here you see the number of fatalities in the United States, which are the black bars, and the fatality rate by vehicle mile traveled, which is the green line, with the years across the horizontal axis. And you'll see that in the United States over the last several decades, we've had a lot of successes in decreasing the number of deaths and the death rate. So actually in 2010, I think it was the lowest number of deaths in the United States since like 1950. So for road traffic injuries, the key risk factors are socioeconomic status. More than 90% of road traffic deaths occur in low and middle income countries. And even within high income countries, the people with lower SES backgrounds are more likely to be involved in a road traffic crash compared to their more affluent counterparts. Age, young adults aged between 15 and 44 account for almost 60% of the global road traffic deaths. Sex, from a young age, males are more likely to be involved in road crashes than females. That's true for all types of injuries. Speed, an increase in vehicle speed is directly related to both the likelihood of a crash and the likelihood of injury and death when a crash occurs. Drink or drunk driving, alcohol use increases the risk of not only a crash happening, but the likelihood of death or serious injury. The risk of a crash significantly increases when your blood alcohol content is above 0.04. Notably, in the United States, the legal limit is 0.08, which is much higher than other countries that we've seen more successes in. Motorcycle helmets, wearing a proper motorcycle helmet correctly can reduce the risk of dying in a crash by 40% and the risk of severe injury by 70%. And seatbelts and child restraints, wearing a seatbelt reduces the risk of fatality among front seat passengers by about 50% and rear seat passengers up to 75%. And then sort of an emergent issue that a lot of research is coming out now on distracted driving. This is an important issue with more people having cell phones and texting. So for global NCDs and injury work, having good surveillance data is key for countries to make informed decisions about priorities and action. So because CDC is such an important part of what because of surveillance is such an important part of what CDC does, I want to mention a couple NCD surveillance models that are being out there. But first, some challenges to NCD surveillance. A common challenge that you hear is sort of a lack of resources and infrastructure. This includes a lack of staff and workforce capacity in training. So key surveillance staff in ministries of health mainly focus on infectious diseases. So making the transition to non-communicable diseases is hard, challenging, and will take time. Additionally, despite the growing burden of NCDs NCDs in many places are really a low priority for the ministries of health. Their expertise, history, and funding often is still in infectious disease areas. And then lastly, for some important indicators and risk factors that we've talked about, there are actually challenges with getting people to participate in those surveys. So for example, diet, which I would argue we don't have really good ways of collecting diet. 24-hour food diaries are actually very challenging and a lot of work to do. For sodium intake, right now the gold standard is actually 24-hour urine intake. Again, hard to do. So WHO has developed an approach for country-level chronic disease risk factor surveillance called STEPS. It's a simple, standardized method for collecting, analyzing, and disseminating NCD risk factor data, and it was designed specifically to be used by low and middle-income countries. So WHO developed detailed manuals and trainings on planning, sampling, data collection, data analysis, which includes things like table shells, epi-info syntax that countries can use when they implement STEPS. The data collection is divided into core minimal information to collect, plus some optional modules for countries depending on what their local interests are. So they have optional modules on things like dietary salt, mental health, oral health, sexual health, tobacco, and violence and injury. So this approach essentially involves 3 levels or 3 steps for risk factor assessment, and data are collected through household visits. So the first step involves a questionnaire that asks things on socioeconomic status, demographics, tobacco, alcohol use, nutritional status, and physical inactivity. The second step involves taking physical measurements of height, weight, waist circumference, and blood pressure, so they don't rely on self-report data for these measures. And then the third step involves taking blood samples and for biochemical measures on things like glucose, total cholesterol, triglycerides. This third step is often only done on a subsample of people. It's actually takes a lot of resources because it involves some lab capacity. And when those resources aren't there, a lot of countries will remove that third step just because they don't have the ability to do it. So it's been done in many, many countries over the last 10 years. Because the data are collected in a standardized ways, countries can compare their findings to other countries in the region and globally, but more importantly, they have data that they can begin using to think about priority setting and planning. So this, for example, is the Tanzania STEPS survey report. Most of the countries that have reported back to WHO, these types of fact sheets are online for those who are interested in, and it includes basic prevalence rates of tobacco use, alcohol consumption, other things that are part of the survey. The other system that I want to mention is the Global Tobacco Surveillance System, or GTSS. This aims to enhance country capacity to design, implement, and evaluate tobacco control measures. And it provides data to countries to collect information on the 6 key elements of the Global Tobacco Prevention Technical Package, which is called Empower. So it includes 4 surveys, the Global Youth Tobacco Survey, which is data collection is done in schools, the Global School Personnel Survey, which is the teachers and administrators of those schools in GYTS, the Global Health Professional Students Survey. This focuses on students pursuing degrees in dentistry, medicine, nursing, and the Adult Global Tobacco Survey, which is basically a country-level survey on individuals 15 and older. So in addition to these 4 surveys, the Global Tobacco Group has also developed something called TQS, or Tobacco Questions for Surveys. Many countries already collect tobacco questions either through independent surveys or adding questions onto larger population-based surveys like DHS surveys. So TQS is an attempt to really standardize how those questions are being asked so that everyone is basically doing it the same way. So for example, if you have a large survey, you really only have room for 2 questions on tobacco. The questions that they suggest you ask are, do you currently smoke tobacco on a daily, less than daily, or not at all basis? And in the past, have you smoked tobacco on a daily basis, less than daily, or not at all? And there are other questions depending on the space available and the interests of countries. So many countries have done these tobacco surveys. 75 have done the Global Youth Tobacco Survey. 33 have done the Global Adult Tobacco Survey. And TQS has been implemented in 12 countries, and actually 12 Chinese cities are also using the TQS questions. Like steps, standardized reporting that go back, all of these are online. This is an example of the fact sheet from Mexico. So in response to the growing acknowledgement that NCDs are a global public health problem, WHO has begun developing a high-level strategic approach for regions and countries to use and adapt to their individual local situation and needs. They started with developing a global monitoring framework, which includes NCD indicators and 9 targets. So for example, there's a target on overall NCD mortality, and the target is a 25% reduction by the year 2025. But then there are other specific targets for tobacco, physical activity, alcohol use, the other main risk factors that we've talked about. They've also developed an NCD Global Action Plan, which is really a roadmap for countries, WHO, international partners like CDC, and private sector entities on what they can do. It includes objectives and specific policy options and actions for each group or target audience that's reviewing it. So at CDC, we're trying to do our part in addressing NCDs, global NCDs and injuries, by supporting capacity building and coordination of activities through our Center for Global Health, which is the center where I work, and providing direct technical assistance on specific projects, surveys, and country requests that are received by our chronic disease, injury, and environmental health centers. Our priorities are hypertension, road safety, and tobacco control. We do other work in cancer registries, violence against children, and developing improving vital registrations. And really our activities include work on surveillance, program development, implementation, and evaluation, and capacity building and training. So really it just runs the gamut. So I'll stop there for now, and we'll see what questions are asked. Thanks.
Thanks so much, Mick, and also thanks, Beth. We have time for a few questions, and there are microphones in the middle. I hope folks who have questions will come to the microphones, and we'll let the speakers take them as they come. So is that a question right there?
Yes, yeah? I am, except it's not on, so I'll just talk loud. I have 2 quick questions. One is about Ebola. There was an article that was published in New England Journal this week, but it doesn't talk about etiology other than an association with fruit bats. So is it urine, feces, is it eating bats, and what's the cause of human-to-human transmission? And my second question has to do with meningococcal updates from the Sahel and the vaccine program for meningitis, and the current college campus situation with B, and is the United States going to approve a 5 serotype vaccine, including B? I'll sit down.
Okay, so we got 3 questions here, and we'll let Dr. Bell do the first on Ebola.
Okay, I think the answer to my question is going to be quick. On the bat, what is it about the bats? We don't know exactly, and it's one of the areas of in quite a bit of interest and study by a lot of groups, including ours at CDC. Obviously, it would be nice to know. In terms of human-to-human transmission, that I think we understand quite a bit better. Human-to-human transmission we find from direct contact with body fluids and blood. And that's one of the things I think about outbreak control with Ebola, is that we do know what to do. And once we actually can do contact tracing correctly, have people's buy-in to what they need to do if they're in contact, and have good infection control in hospitals with early identification, we really know how to stop transmission once we recognize cases. But how is it that the bats transmit to the people, I think, is still to be determined.
So in terms of the meningococcal A issue, meningococcal meningitis A is a huge problem in sub-Saharan Africa, but one of the most extraordinary public-private partnerships I've ever heard of was the Meningitis Vaccine Project, which developed a low-cost meningococcal A conjugate exclusively for Africa, a partnership of Serum Institute of India, PATH, WHO, CDC, and IBSC, all funded by the Gates Foundation. Over 150 million people in Africa have received the Meninge A conjugate so far. There are 0 cases of meninge A in anyone who has gotten that vaccine. Absolutely extraordinary. Improving surveillance for meningococcal meningitis, including the typing. We're uncovering other groups that are prevalent, but it's not finished yet. There's still populations that will be getting this mass vaccination and expected introduction of a conjugate into the infant schedule. So it's a really exciting advancement. Meninge B was in the news for outbreaks in Princeton and at the UC Santa Barbara, where IND expanded access Meninge B vaccine produced by Novartis with the IND sponsored by CDC was used on those 2 university settings. The company had planned initially to go for licensure of a 5-valent vaccine and hadn't yet applied. I think is reconsidering whether they'll try to get the Meninge B product licensed for the US. It's already licensed in other countries on the way to the 5-valent one. But it's very exciting to have a Meninge B product that appears to work based on the studies that have been done so far, as that's been decades in coming. Wow, we have a lot of questions. Okay. You in the white? Yeah.
Hi.
Uh-huh.
So I'm a science and research advisor at USAID, and I really appreciate your comment on the tension between thinking and doing in terms of research. And so my question for the entire panel actually is, with that tension that tension and kind of the focus on research, that every dollar counts, I think what often happens is that we want to do the best research as fast as possible, which means we go to our experts at CDC, at Johns Hopkins, at US universities, and sometimes the focus on building capacity in developing countries is not a priority. So I wanted to ask, from your experience and long time experience working in Africa and these countries with a lot of infectious diseases, where do you see the gaps are in capacity, or where do you see also some successes? And what do you see we can do as donors and as universities to actually take the capacity and training component into consideration? Mm-hmm. Thanks.
I guess I think that one of the things I was trying to show by some of the examples in Uganda is that there is a very strong correlation between capacity that's targeted towards what we know are our major problems, and especially capacity where we know what kind of capacity needs to be strengthened. There's a direct correlation between that and disease outcomes and improvements in health for people in the country. And so I think this is a story that repeats itself over and over again, where the benefits of, especially in situations where we know enough about the condition in question, that, as I say, we can target our capacity based on what we know is going to make a difference, that this kind of targeted capacity building can yield health benefits for the people of the country in question. And to me, that's a large part of the picture in many situations. I think we've seen this over and over again, that in order for countries to have some sort of buy-in and understand that it's not research for the purposes of research or for building somebody's career, it has to be clear what the benefits are for the country. And sometimes I think that's well known. Other times I think that's something that needs to be developed in the context of new initiatives. I mean, I, for example, remember back with Gavi, when it was first starting, and hepatitis B vaccine was one of the first, quote, new expensive vaccines that there was some interest in introducing, and countries would say, why should I bother to do this? We don't have any problem with hepatitis B. Or Anne's example about Hib in India is another example of that. And so I think that what it took was providing some relatively easy ways, to your point. There was a computer model, for example. You put in a hepatitis B anti-core prevalence and a couple of other things, and you came out with an answer about how much hepatitis B you might have in your country. That can show to ministers of health and ministers of finance what the point is, what the point of capacity building is, or what the point is of implementing a new public health program. I think that, in other words, this idea of tying the research to some outcomes is a really important part of building interest and acceptance, and in fact enthusiasm about what is kind of, science-based capacity building. And I think we certainly have, for example, have seen that in Uganda.
Great. We have a lot of other questions, so I think we'll move on. Next.
Hi. I really appreciate the disease backgrounds, even the simplified stuff you've been giving me, because I am a engineering graduate student, much more of the manufacturing side, who's working with a malaria magnetic filtration device. And I've only just started researching on Plasmodium falciparum. And I was wondering if you could give me any of your own knowledge about that, regarding possibly how it's been progressing in sub-Saharan Africa, and how you think it's getting worse or better, what treatments, and how you think that's developing at this time.
The world of malaria has come a long way in the past 10 years or so, with a lot more investments and focus on actually using what we know, and then also pushing the envelope into even an eradication agenda. But the U.S. government's contribution is generally part of the President's Malaria Initiative, and PMI has actually had an enormous impact on increased use of nets, increased use of insecticide, indoor spraying, and actually has documented reduced deaths and increased health. So it's actually a very nice set of accomplishments. But that doesn't mean that the research questions are gone. And as new kinds of resistance emerge in different places, or there's a up and down cycle to the health benefit, I think there's been a revisiting of how important it is to actually do operations research, or to do better monitoring and actually understand, not just buying the products and making sure they're used, but understanding the effect. So I think none of the three of us are the malaria experts in this room, but I'm aware that there's been a lot of progress, but a little bit more attention to making sure there's strong monitoring in the context.
Who is PMI? I haven't heard that before.
PMI stands for President's Malaria Initiative, and it's sort of like the PEPFAR of malaria, but as malaria experts would say, it's a baby PEPFAR, because it's not as well funded at this point. And USAID has the lead, and CDC's part of it, with resident advisors in a number of countries. Tim.
Yeah, good afternoon. Tim Mastro with Global Health at FHI 360 in Durham, North Carolina, and Washington. A question for Mick Ballesteros. Nick, that was really a terrific overview of the global picture of NCDs. And it's been nearly 3 years since the UN high-level meeting on NCDs in 2011. And I was at a meeting in Zambia last week, and it was made very clear that there's remarkably little infrastructure and screening for NCDs. Often healthcare facilities can't take a blood pressure. There's no glucometers, can't weigh a patient. There seems to be some growing interest in pharmaceutical companies in looking at the African market, because they see it as a market for diabetes management, hypertension, and NCDs. So the question is, do you see any signs of increased funding by international organizations or international entities to support developing countries' NCD efforts?
Yeah, so I guess the short answer is I don't know. I think that's the hope. One of the things that we're trying to do is leverage other opportunities with infrastructure that's already there in terms of other programs. But the funding is an ongoing challenge. It really is. And to be honest, I just don't have the answer. But I know that people are talking about it. So.
Yeah, sure. It's going to take sort of continued advocacy just to put it on the radar screen so people don't continue to present with stroke as their first sign of hypertension. But thanks for a great talk.
Yeah, let me just make a comment on the Ncd Resource Investments. I think it's clear that it's an increased priority to ministries of health around the world, to WHO, to CDC, to many partners, because it is what is killing a lot of people right now, including the leaders in a lot of these countries. There are political challenges with big investments, at least in terms of the generic NCD agenda in the US anyway. But there's opportunities to make impact indirectly through the many capacity building activities. One of the nice things that CDC has done recently is use our field epidemiology training program as a platform and develop an NCD curricula that can go into that, because the FETP is in dozens of countries. When you can train future ministry staff and leaders in the problem of NCDs and what needs to be done about them, you can start to get that momentum in terms of solving the problem. I've talked to companies that make vaccines but also make antihypertensives that are very interested in the market. And often when companies are interested in the market, they're willing to invest in some infrastructure. So I don't think it's hopeless, but I don't think that the U.S. Congress is about to give us a big initiative of resources strictly for global NCDs. Let's see, I think you would be next.
Karen Gorleski with the American Society of Tropical Medicine and Hygiene, and I really just have a comment. I'm very pleased to see infectious disease with chronic, with injuries on the same panel at a global health meeting, and at ASTMH we're certainly looking at some of this as well. So I welcome a symposium like this for the next ASTMH meeting.
Thanks very much. Last question?
Thank you very much for a very enlightening session. I would frame my two questions to the speakers under the theme of global health collaboration. So Dr. Bells, I would like to ask you, in understanding that CDC seconds quite a number of professionals to WHO, if you could highlight the pros and cons of working in the direction of bilateral relationships versus CDC actually offering its technology, as you have presented, and also its skills through a WHO collaboration. And to make, if you could present some examples of how does the US learns from the northern European countries, the UK in the area of road injuries, road accidents that you have demonstrated in order to reduce incidence of death and morbidity here in this country, learning from their experience, if there are any examples. Thank you.
At CDC we use actually lots of different models for working around the world. We have a number of places where we have CDC offices in many countries around the world. Some of them are directly tied to programs like PEPFAR, for example. Others are sort of affixed to, or sort of more of a conglomeration of various different kinds of programs. We do have a lot of also secondments to WHO offices, particularly the polio program, and the global immunization group uses that model oftentimes. We've seconded people to WHO directly, to regional offices. And I think, as I say, there are a number of different kinds of models. I think sometimes it's somewhat dependent on what the task is, what the objectives are, and also, frankly, somewhat dependent sometimes on our own resources. There are many situations for many pathogens or infectious disease problems where CDC, frankly, doesn't have the resources to second people, and really rely much more on collaborations directly between CDC and a country, or collaborations with WHO, asking CDC to assist in missions or in certain evaluations, or that, and those kinds of areas, really, because as I say, for many things we really just don't have the resources. So I think it's sort of mostly a matter of what is the best model to get the particular job done. And I'd say there isn't really one answer. We try to be we are pretty diverse in terms of the kind of makeup of our global footprint in the many, many countries in which we work. In Uganda, for example, while most of our resources are around PEPFAR, we have now President's Malaria Initiative, we have an immunization person, and we have several people that are working directly on viral hemorrhagic fever and plague, all integrated together, but in a collaboration with other parts of the U.S. government and also other groups from other parts of the world and the WHO Afro office all sort of, working together. Your question? Yeah. Go ahead.
Yeah, so just in the area of road traffic injuries, as I showed, a lot of European countries do a lot better than the United States. I think we actually have a pretty good relationship with at WHO, the Injury and Violence Group is actually organizationally different than the Chronic Disease Group. So the Injury Prevention Center at CDC works directly with the injury and violence people at WHO, and I think we have a pretty good relationship with them. The director at WHO actually was a former EIS officer at CDC. So a lot of it's the collaboration between CDC and WHO in terms of what CDC can contribute. But I think, as Beth mentioned, especially in the area of injury prevention, I think the staff capacity and the resources are pretty limited for road traffic injury prevention work. But there is a lot that I think we can learn from some of the European models that have happened where the death rates are dramatically lower than the United States.
Great. Thank you so much to the speakers and to the audience for good questions and comments, and enjoy your lunch.